Hi, everyone, and welcome to today's webinar. I'm going to be talking about 2025 Physical and Occupational Therapy Billing and Coding. My name is Zachary Edgar, and my company is called Therapy Comply. This webinar is being recorded, and immediately after the live presentation, I'll send out a link to everyone who registered, and you'll be able to access this at any time. If you have any questions, please feel free to send me an email. I won't be answering questions during the webinar, but I will be happy to answer your questions after. Just a little quick thing. So Therapy Comply is a membership-based compliance firm dedicated to assisting physical, occupational, and speech therapy practices and facilities. Members can access a wide selection of guides, sample policies, and forms on Medicare, Medicaid, HIPAA, TRICARE, and state laws and regulations that apply to therapy practices. Members can also email me at any time with any compliance or billing questions or schedule a phone call. Please visit the website at therapycomply.com for more information. Disclaimer, this presentation is for informational purposes only. None of the material is intended as legal advice. Statutes and regulations, along with guidance and both public and private payers, are all subject to change. So on the agenda today, I'll first be talking about some documentation tips just to make your documentation a little bit stronger. This information is from Medicare, and that typically leads the way when it comes to the other payers as well. So it's a good place to start. And throughout that, I'll be talking about other important things like the AMA rule versus the total time rule, kind of how you do that and which payers, and I'll talk about the end, which payers do which. I'll talk about the NCCI Edits, kind of where that stands right now for therapy. A little bit about utilization and how payers are looking at that today. I'll talk about modifiers, and finally, I'll talk about some kind of key billing points for some of the major private payers. So this is general tips on documentation. The medical information submitted should paint a picture of the patient's impairments and functional limitations requiring skilled intervention, describe the prior functional levels to assist in establishing the patient's potential and prognosis, describe the skilled nature of therapy treatment provided, justify that type, frequency, and duration of therapy is medically necessary for the individual's patient's condition, clearly document both time code treatment minutes and total treatment time in the order to justify the units billed, identify each specific skilled intervention modality provided to justify coding, and provide outcome measures or results of other assessment tools or measurement instruments as appropriate to demonstrate the clinical progress being attained by the patient in regards to the patient's identified functional limitations. So kind of more specifically to each part of the documentation. So the initial evaluation should document the medical necessity of a course of therapy through objective findings and subjective patient self-reporting. Documentation of the initial evaluation should list the conditions being treated and any complexities that make treatment more lengthy or difficult. This is particularly important if you're going to have a long episode of care. So if you're planning an episode of care that's more than, say, 20 visits, you really want to make sure your documentation justifies why it's going to be longer than that amount. The initial evaluation establishes the baseline data necessary for assessing expected rehabilitation potential through functional testing, uses standardized scales appropriate to the patient's diagnosis, the setting of realistic goals, and objective measurement of progress using these same scales. So it's important, you want these objective measurements that you use in your evaluation. You're going to use them for every progress note that you do. So every 10 visits, when you have to do that progress note, you're going to want to use those same objective measurements to show that progress. That's a kind of a really important when you're doing Medicare for Medicare patients, and I think it's also important if you do this for other patients as well. Even if the payer does not require you to do a progress report at any given time, it is still a good way to measure the patient's progress. And if you do include it in your documentation, and there is an audit by a payer, that's going to give you really strong evidence that the therapy is working and it's justified to continue. So it's a good idea it's something to consider doing progress notes, even if the payer doesn't want you, just to measure the patient's progress and strengthen your documentation. Initial evaluations need to provide objective, measurable documentation of the patient's impairments and how any noted deficits affect ADLs, IADLs, and result in functional limitations. And functional limitations must be meaningful to the patient and caregiver and must have potential for improvement. In addition, the remediation of such limitations must be recognized as medically necessary. So just a long list of what the evaluation should include. These are some, good tips here. The presenting condition or complaint. So why the patient needs therapy. Patient should exhibit a significant change from their usual physical or functional ability to warrant an evaluation. Provide objective description of the changes in function that now necessitate skilled therapy. Simply stating decline in function does not adequately justify the initiation of therapy services. Diagnosis and description of the specific problems to be evaluated. Include the area of body and conditions and complexities that could impact treatment. Subjective complaints and date of onset. Relevant medical history, applicable medical history, medications, prior diagnostic imaging and testing, and prior therapy history for the same diagnosis, illness, or injury. The last one is, this is just half the list, but this is important here. If you have a patient that was already in therapy, maybe you discharged them a month or 2 months ago and they're coming back from the same condition, you really do want to address that in the evaluation, why they were discharged and why they're now coming back. If you don't address that, and you do get audited, because this is a red flag. If you have multiple evaluations throughout the year with the same patient, that's a red flag for payers. So you want to make sure if you do get that, if you're doing that and you do get audited, you at least have it in your documentation justifying why the patient is now back for a new evaluation. And this is just what I said here. If recent therapy provided, documentation must clearly establish that additional therapy is reasonably necessary. Social support environment. So this is something when I do audits of therapy documentation, I see often left out, but it is good. It is really good to have that in note, their social support environment, especially when you do a home exercise plan. You may want to note if they do have a caregiver or someone, a spouse, adult child, someone like that who can help them with those services or help them with anything they need while they're in rehabilitation. Does the home situation have obstacles the patient may overcome, such as stairs without handrails, anything like that? This is important for a patient who's susceptible to falls. You may want to note if there's anything that makes in their house that, discuss this with the patient, that may increase their likelihood of having a fall while they're in rehabilitation. What are the patient's usual responsibilities in the home environment? Things like just walking a dog or doing yard work can increase those risk levels. Prior level of function, key piece of information using established potential, prognosis, and realistic functional goals. Functional status just prior to the onset of treating condition requiring therapy, and record in objective measurable functional terms and objectively measure or describe the patient's current level of functioning. Objective impairment testing, so testing done to determine the source or cause of the functional limitations, such as range of motion, manual muscle testing, coordination, tone assessment, balance. Use concise objective measurements. Avoid minimal, moderate, severe types of descriptions when more specific definitions or measurements are available. And for example, when measuring shoulder flexation, document degrees of motion rather than documenting shoulder flexation, minimal loss of motion. So the real degrees, objective measurements, those are the keys. Points to use. In your diagnosis, the diagnosis should be specific and relevant to the problem being treated as possible. In many cases, both medical diagnosis obtained from the physician or MPP and impairment-based treatment diagnosis is relevant. Build the most relevant diagnosis. When billing for therapy services, the ICD-10 code that best relates to the reason shall be on the claim. So, and if you're not very familiar with ICD-10 codes, they're very specific. And what I often see in my audits is therapists would use kind of the most general ICD-10 code as they can when there's a lot more specific codes. And this can often result in claims being denied. And so you do want to get a good handle on the ICD-10 codes, and so you can be as specific as possible when doing your diagnosis and putting that on the evaluation and on the claims. So you want to make sure to really kind of study up on those codes to make sure you're using the closest one to the patient's condition as you can. Another thing is when a patient with when a patient with diabetes being treated for gait training due to amputation, the preferred diagnosis is abnormality of gait, not diabetes. So you want to be specific to what they have going on with therapy, and not general diagnosis such as diabetes, which, well, something can be dealt with therapy. With therapy, you are focusing on that abnormality of gait in therapy, not diabetes specifically. When a claim includes several types of services, or when the physician must supply the diagnosis, it may not be possible to use the most relevant therapy code in the primary physician. This can be due to state law. Some states don't allow you to do the diagnosis. They do require diagnosis from a physician, but you can have a secondary diagnosis, therapy diagnosis. So you should also be aware of the state law when it comes to diagnosis and who has to give the specific one. So this goes now into plan of care. Your long-term goals should pertain to the functional impairment findings documented in the evaluation, reflect the final level the patient is expected to achieve as a result of therapy in the current setting, be realistic, and should have a positive effect on the quality of the patient's everyday functions, be function-based and written in objective, measurable terms with a predicted date of achieving the goals. So long-term goals, this is particularly true with Medicare. Long-term goals are required. Short-term goals are optional, but you do need to have the long-term goals in your plan of care. You can't just have short-term goals, but you do need these long-term goals. And also, an important note: if long-term goals do change over time, you do need to have a physician or NPP recertify the plan of care if the long-term goals have changed. If you don't change the long-term goals, but you change other aspects of the plan of care, you don't need to have that recertification. Only when you change the long-term goals do you need a recertification. But and though you do also need that 90-day certification anyways. The type of treatment, you need to include this. The type of treatment includes the type of therapy, discipline operating on the plan of care. That's either physical, occupational therapy, or speech therapy, and should describe the types of treatments, modalities, procedures, or interventions to be provided. This is you do need to specify PT or OT, but you don't necessarily have to specify every single modality or procedure you're going to do. You can give a list of them, and that can change throughout therapy. The amount of therapy refers to the number of times in a day. The type of treatment will be provided. Where not specified, one treatment session a day is assumed. Treatment provided more than one session per day per discipline will require additional documentation to support that amount of therapy. That's going to be very rare situations. Frequency refers to the number of times a week. Treatment more than 2 or 3 times a week is expected to be rare. Treatment more than 3 times a week requires documentation to support that intensity. So if you do plan on doing more than 3 times a week, you do need to specify why. So you do need to specific in your documentation, you address that why the patient needs therapy more than 3 times a week. And duration refers to the number of weeks or number of treatment sessions for the plan of care. The therapist could estimate the duration of the entire episode, but you can also give a general. You can say 12 weeks, 16 weeks, 6 weeks, and that can change throughout therapy if necessary. Certification of therapy plan. So you have 2 options. So you can have that plan of care signed and dated by a physician or an NPP, but you can also with Medicare now accept a referral. So this is just certification requirements. You get them signed and date the plan of care. Usually you're going to want to do that within 30 days of when you start therapy, or 14 days after a verbal order. I just want to highlight here the order of referral. So now you can do this. You can get a signed and dated order of referral from a physician combined with documentation such as in the patient's medical record, along with further evidence in the medical record that therapy plan of treatment was transmitted. So if you get this order referral from a patient, they come to you with the order, all you have to do is transmit the plan of care to the physician. They don't have to sign it, but you do need a record of that transmission to the physician, whether you do that by fax or whether you do that by email, it doesn't matter, or by EHR, you just need a record of that. And then once you have that, you don't need that plan of care signed by them, but you do need that recertification of the plan of care after 90 days. So you still need that recertification, whether you have the plan of care certified or you have that referral. So in either method, you do need that recertification after 90 days. Right now, there has not been any additional specific guidance on the order of referral. But it must be written, dated, and signed by the ordering referring physician and include the type of therapy, so physical therapy, occupational, speech therapy that the patient requires. And the order of referral must also include information to identify the patient and identify the physician. So that's kind of the bare minimum of what needs to be in the order as of now. Reevaluations. Reevaluation documentation must include clear justification for the need for further tests and measurements after the initial evaluation, such as new clinical findings, a significant unanticipated change in the patient's condition, or failure to respond to the interventions in the plan of care. It is expected that therapists continually assess the patient's progress as part of the ongoing therapy services. This assessment is not considered a formal reevaluation. The time of the assessment is included and billed within the appropriate treatment intervention CPT code. This is important with Medicare. Do not bill reevaluations periodically. You do not do a reevaluation and bill for one every progress date. So a lot of therapists do that, but that's something you cannot do. Reevaluations are only going to be done if there's a significant change in the patient's condition that warrants a reevaluation. Again, if you have any questions, feel free to email me. I won't be answering them during the webinar. I do plan on putting this the recording on YouTube, so you probably don't want your name popping up there anyways. So that's just another reason why you just send me an email if you have any questions, and I'll be happy to answer the emails throughout the week. So we'll do it that way just to make things simpler. Treatment notes. Treatment notes must include the following required information. This is the absolute requirements. The date of treatment, the identification of each specific treatment, intervention, or activity provided in the language that can be compared with the CPT codes to verify correct coding, a record of the total time spent in services represented by time codes under the time code treatment minutes, record a record of the total treatment time in minutes, which is the sum of the timed and untimed codes, and the signature and credentials of each individual that provided skilled intervention. In addition, so these are things that can add to the note, add to medical necessity, and I definitely recommend you consider this, especially if you have if you're doing a lot of utilization, if you have a long episode of care, you have the patient in over at least maybe over 4 units, or at 3 units or more. You're going to want to put more information to justify medical necessity. So these are some of the things you can put in there that can help. Patient comments regarding pain, function, and completion of self-management in home and exercise program, significant improvement or adverse reaction to treatment, significant or unusual or unexpected changes in clinical status, parameters of modalities provided and or specifics regarding exercise such as sets, repetitions, and weight. This is an important part too. I know a lot of people use flow sheets where they keep track of the exercise, the sets, the repetitions, and weights, and don't include that in the notes. I would recommend putting more of that information in the notes rather than always referring to the flow sheets. One of the things I've been seeing when it comes to payer audits, this is Medicare and a couple of the private payers that I've seen, is that when they will often, if that information is not included in the notes and it's just in a flow sheet and the flow sheet's handwritten, they will often say that it's not legible and throw out the entire note and the claim along with it. So putting that information in the EHR will strengthen your notes instead of just relying on flow sheets that are handwritten. Description of the skilled components of specific services, exercises, training, or activities, instruction given for the home exercise program, restorative or self-giver managed program, including updates and revisions, communication, consultation with other providers, if applicable, communication with the patient, family, or caregiver, if applicable, any equipment that was provided, and any additional relevant information to support that the patient continues to require skilled therapy and that the unique skills of a therapist were provided. This last one, this is really going to be in your progress report. It doesn't need to be in every note, but the other things should be in the notes. They will definitely strengthen your documentation. Time, so the total time code treatment minutes and the total treatment time in minutes. So this does need to be part of your notes. So you're going to have the specific time of each one of your time codes, and you should also include the specific time of any untimed codes, just so you, and then the total time. So you want to make sure that all evens out. So again, the total the time spent on each specific time code, time spent on the untimed code, and then the total time of the treatment altogether. And even you don't have to put in time of the unbilled services, but if you show that overall, and you can identify that these time spent that wasn't billed for, but you don't need to, it just can strengthen your documentation. You just want to make sure everything adds up. So you want to use the CMS language, time code treatment minutes and total treatment time. Do not use any other language or abbreviations when referring to treatment minutes, as it may be difficult for the medical review to determine the type of minutes documented. So do not record time as time in, time out for the entire session, as it does not accurately reflect the actual treatment time. So again, you're going to over the actual time spent in treatment, the billable time. 8-minute table. So this is the rule, this is the table. Of course, you're going to use both of the AMA rule and the Medicare total time rule. This is why it drives me a little nuts when people always say the 8-minute rule, because both of them really are the 8-minute rule. So you don't, I say, either be specific with the AMA rule or the Medicare total time rule or total time rule when referring to it, the different rules. All right, and I'll show you some examples of kind of how these work out to be different in some cases or the same in some cases. So for example, here, 20 minutes neuromuscular ed and 20 minutes therapeutic exercise. Those would be 1 unit each if it was the AMA rule, but when you're using the total time rule, you combine them, which is 40 minutes or 3 units. So in this situation, you would have either 2 units of 97112 with 1 unit of 97110. Because they're the same time spent on both of them, you can put it on either one, the extra unit on either one. If you do have more time spent on one rather than the other, you're going to put those 2 on that one and 1 on the other one. And then with the AMA rule, you just get 2 units instead of 3. Here's another case where you lose out on the total time rule when you have 24 minutes, so you spent at least 2 minutes on each, 24 minutes on neuromuscular, 23 minutes on therapeutic exercise, so 2 units each. The combined total is 47 minutes, so 3 units. So Medicare, it would be 2 units of 97112 and 1 unit of 97110. And then with the AMA rule, you get 2 units of each. And in most cases, you're going to find that the AMA rule nets more units than the total time rule. But if you're trying, you can play around with the minutes to see which one is better for each one. Here, again, this one works out better for the total time rule, because in this case, 7 minutes manual therapy, 7 minutes is not enough to be a unit, but with Medicare, the total time rule, you can add them up, and even though that was just 7 minutes, you add that to the 36 minutes and get 40 total time, so you get 3 units there, and you can allocate that extra unit to 97140, even though it was under 8 minutes, because you have that extra unit with the total time. But with the AMA rule, you're only going to get 2 units of 97110 therapeutic exercise, because you didn't spend enough time, the 8-minute minimum on that on 97140 on manual therapy. Here's the time when you're going to get better results with the AMA is usually when you do more procedures or modalities. As long as you're spending at least 8 minutes on those, you're going to get a unit. So by spending, even though all these are just 1 unit, but they're all different, you're going to get 4 units for each one. And the total time being 49 minutes, you're just going to get 3 units. Of course, spending more time on each is going to put you over and can get you over that total time rule as well. But again, I just want to highlight that the more services you provide, usually it's going to be better with the AMA rule versus the total time rule. All right, and I will talk at the end when I get to private payers on which payers choose which ones. It can be confusing because no, I've yet to see any private payer come out directly and just say we use the total time rule. Other than United Healthcare says that they follow the CMS guidelines, but other payers, if they do use the total time rule, it's usually they will poorly describe it rather than just come out and say we follow the Medicare rule. Progress reports. So progress reports provide justification for the medical necessity of treatment. They're really going to be these are really where you highlight your medical necessity, where you justify ongoing therapy. It does need to be done at least once every 10 treatment days. There are in some local coverage determinations, they say at least once every 10 treatment days, or every 30 days, whichever is shorter. That is only in the local coverage determinations. That is not in the Medicare manual, the benefit manual, which gives you kind of all the information about documentation and what you need to do. So I say because of that, just stick to the 10 treatment days. You can, if 30 days is less than 10 treatment days, and you can do that as well if you want to do that. There are a lot of states that do require periodic reassessments of the patient. Can be every 30 days, can be every 6 visits, every 20 visits. It's different from every state. You got to double check your rules, but that is also those are specifically, in many cases, when you're using an assistant. If you're just using a therapist, you may not need to do those state reassessments. So here you can just stick with that 10 treatment days, but really whatever works for you, as long as that is kind of the maximum amount of time before doing a progress report. You can do them more frequently if you'd like. And this starts for the first report, it starts on the first day of treatment, the evaluation, so that's your day 1, and the subsequent reporting periods start on the treatment day after that progress report. During each progress report period, the therapist must personally furnish at least one billable service of 1 unit, at least 1 day of treatment. So if you do have your assistants doing most of the day-to-day therapy, you do have to do at least 1 unit with the patient during that progress report period. The therapist needs to. And verification of the therapist's treatment shall be documented by the therapist's signature on the treatment note and/or progress report. And you want to make sure that unit does not have a CL or CQ modifier next to it, that it was just done by the therapist. Progress note elements include the date of the beginning and end of the reporting period that this report refers to. That's often left out of progress reports, but you do need to have that first, you do have to do the reporting period, show that the dates on there. The date the report was written by the therapist, also their signature and all that. Objective reports are the patient's subjective statements if they're relevant. I always think the patient's information, their subjective statements and how they're doing is very relevant. I think most therapists would agree with me. Objective measurements. So these are back to those objective measurements that you did in the evaluation. You want to make sure you're using the same objective measurements that you use in the evaluation as in each progress report. That's really what shows how you're quantifying the patient's progress and to support justification for continued therapy treatment. Description of the changes in the status relative to each goal currently being addressed in treatment. Description shall make identifiable references to the goals in the current plan of care. Assessment of improvement, extent of progress or lack thereof towards each goal. If there hasn't been any progress, you're going to want to address that, why there hasn't been progress, whether it's because the patient is not doing their exercises or something like that, or if the patient had additional injury, anything like that why there's no progress and to justify continued treatment. And this goes into plans for continuing treatment, including documentation of treatment plan revisions as appropriate, changes to long or short-term goals, discharge, or an updated plan of care that is sent to the physician. So again, if you do change your long-term goals in that during the progress note or at any time, you do need to have that recertified. And then the signature with credentials of the therapist who wrote the report. An assistant can assist with the report. They can do objective measurements and things like that, but ultimately it's going to have to, the therapist is going to have to overall do the report. Well, they can use the objective measurements from the assistant. The overall assessment and the plans for continuing treatment does have to come from the therapist that's doing the report. Discharge. So a discharge note is required for each episode of treatment. It must be written by the therapist. Discharge note is a progress report covering the time from the last progress report up to the date of discharge and includes all the required components of that progress report. The discharge note may be considered the last opportunity to justify medical necessity for the entire treatment episode. So that's why it's important. If the discharge summary has been completed, it may be prudent to submit it with any request of records for medical review, even if the claim under review is for treatment period prior to the date of discharge. So even if you do have a claim that's under review and you do have a discharge note, you're going to want to do that. Unanticipated discharge. So in the case of an unanticipated discharge, the therapist may base any judgments required to write the report on treatment notes and verbal reports of the assistant or the therapist themselves, whoever did the treatment. So even if the patient just stops coming in for treatment, you still need to do a discharge report. You can base it off of what the progress the patient made based off of the last notes, where they were in the last progress report, whatever you have, but you do need to do a discharge summary. You can't just say forget about it because the patient left. Too many therapists do that, and you do need to have this, does need to be part of the documentation. Not only is it a requirement for Medicare, it's a requirement for many other payers, and often state law, state regulations require discharge notes in documentation as well. All right, so NCCI. So I'll go over this, but I want to highlight that there really has not been any notable changes to NCCI and therapy services since about 2020. So it is not something you really generally going to have to worry about it. I go through quarterly to see if there's been any changes, and I put them up on the website, but there really has not been anything significant, again, since 2020. But I will highlight some of the ones you just want to look out for. I'll first be talking about the procedure to procedure edits. So these are when you have two codes that are billed on the same day that are incorrect code combinations. So Medicare puts out these massive code volumes where you have a code and a whole list of other codes that you can't bill on the same day. Sometimes you're allowed to if you have the modifier, and I'll talk about that modifier, but sometimes you're not allowed to, and you just kind of see whether it's a 0, which means not allowed, or a 1, which means allowed in the code tables. And there are two different kinds of NCCI edits, PTP edits. There's the practitioner ones. These apply to claims filed by physicians, non-physician practitioners, ambulatory surgery centers, and any therapist that's private practice, or if you're a therapist who's working in a physician group, these apply to you. If you are in the hospital edits, so if you're in an outpatient hospital, Part B skilled nursing facility, a CORF, anything like that, or outpatient rehab, then you look at the PTP hospital edits. So you want to make sure you're looking at the right ones. There are differences in the code tables. So you want to make sure you're looking at the right one. So the first rule is evaluation. So just the OT, and this applies to PT as well. A PT or an OT may report only one evaluation or reevaluation on a single date of service. In this case, goes for practitioners and for facilities as well. So you can only do one evaluation, and same with assessment codes as well. Some of those other assessment codes you cannot do on the same day as an evaluation. We'll get to that. So this is kind of how I put these things together, where you say, okay, you have your main code 97161, and then what codes are allowed with a modifier and what codes are not allowed. So you'll see other assessment codes here, reevaluation codes that you can't even if you use a modifier 59 or the X modifiers, you can't use that. So again, same thing with the OT evaluation, and these are the same with the medium high as well. Same again, the assessment codes that you can't bill with. Reevaluation. So these are reevaluations should only be routine. They shall not be routinely reported during a planned course of physical or occupational therapy. And there are a number of codes that you cannot bill with reevaluations as well. Again, these assessment codes down here you'll see not allowed even with a modifier. Mechanical traction, just an example. You can with a modifier bill with a reevaluation, but you do need, so if you do a reevaluation, you're going to be wary, and you do Therapy on that same day, you want to make sure you're using a modifier as well. And that's generally going to be, you can use either modifier 59 or modifier XU. So same here, electrical stimulation. If you do it on the same day as a reevaluation, you're going to have to use a modifier. So these are kind of the little things you're going to look out for with NCCI. Again, with the assessment codes 97750, 97763, and 97755, these are the codes that you're not going to be able to bill on the same day as an evaluation or reevaluation. And then again, I just highlighted it here so you can see. Orthotics, again, so pretty simple stuff, really. You know, just no assessments in the same day as reevaluations. Some of the more kind of the therapy codes that were with other procedures or other modifiers, those were all removed in 2020. So it made things a lot easier with NCCI and therapy. Again, orthotic management, you just can't bill in the same day as the reevaluation codes and the evaluation codes as well. When there's any question of the codes, you're going to want to look at both codes, not just one, because a lot of times you'll see a code and then it won't be allowed with, and there's another code. Like for example, here there are no evaluation codes on here, just the reevaluation codes. But if you look at the evaluation codes, 97760 will be on there. So you can't bill those on the same day. Another important note is that it does not matter which code you append the modifier on. So you can do it on either one. Again, just showing here 97761, prosthetic management. You cannot bill on the same day as reevaluation, and you also cannot bill on the same day as an evaluation as well. Group therapy, these have a number of more codes that are with modifiers than you see with other regular procedures. So if you do group therapy, you want to be aware that there's other codes that you cannot bill with them or that need a modifier. Again, 97140, 53. So quite a bit of codes here. And then you can't, so just be aware of that when you're doing group therapy. Modifier 59, a lot of practices still use 59. You're still allowed to. Some payers are a little bit more strict. They want to see the more specific X codes, which I'll talk about. But modifier 59 means that and that's when you see allowed with a modifier. That means that you can use modifier 59 if you bill those codes on the same day. If it falls under that category, not allowed with a modifier, then you can't use modifier 59 or any else. And so documentation, when you do use modifier 59, you do need to document it as well. And the documentation must support a different session, different procedure or surgery, different site on the body, separate incision, separate injury, and or not ordinarily encountered or performed on the same day. So you do need to justify it in your documentation. And the more appropriate modifiers, so XE, separate encounter. This service is distinct because it occurred during a separate encounter. Usually a different visit, even if it's in the same day. Only used to describe separate encounters on the same date of service. Separate structure. So if you're doing different therapy in a different part of the body, this is not as relevant anymore because, again, most of those procedure-to-procedure edits were removed. Separate practitioner. So if the person is going to see a PT and OT on the same date of service, you may want to make sure you may use XP if you're going to have an overlap in assessment codes or something like that. And then, so for example, if the patient is seeing a physical therapist for an injury, but they're also seeing an OT for an orthotic prosthetic, and they may have an overlap there, codes that can't normally be built together. If you use XP on either one of those codes, you're going to be able to use that. And XU is unusual non-overlapping service. So this is going to be used when you're doing that reevaluation and a modality or procedure that can't normally be billed with the reevaluation. So that's when you use XU as the most important appropriate one. Again, this is just a rehash of that. I'll move forward. Medically unlikely edits. So these are the the maximum number of units that actually the patient can receive during a day. So even if you have multiple providers, if you're at these medically unlikely edits, you can't do them more than once a day, or more than those number of units a day. I'm going to show you kind of what these look like. So for example, and again, practitioner edits and hospital edits are different, so you want to make sure you're looking at the right code sets for your setting. Therapeutic exercise, maximum of 6, neuromuscular rehab, maximum 4, aquatic therapy 6, group therapy 1, mechanical contraction 1, e-stim 4, and there's 3 here. This means that if you go over, you can appeal. If there's a 2 there, that means you cannot appeal. For example, where you'll see a 1, and this should actually be a 2 here, evaluations, you can only do 1 a day, and it's not appealable to do more than 1. Facilities, you'll see here that there's more. So in a facility, you can provide the medically unlikely edits are just higher for most of those services, but the same with mechanical contraction, same with evaluation, but now 8 units for therapeutic exercise, 6 for neuro ed. This doesn't really matter so much because even though these are hard caps, most payers will only pay maximum 4 units per day now. And though with Medicare, 4 units a day is a utilization guideline, not a hard cap. But for most payers have hard capped 4 units per day now. This is just kind of a overview of what each thing means. But again, it's pretty straightforward. You have the code, the description, the code, and the maximum amount of units you can do in a day. And the third is the type of the adjudication indicator, whether that you can appeal it or you cannot appeal it. Some just guidelines on Medicare utilization. So generally, therapy sessions should be no more than an hour. That's true for basically every payer now, an hour, 4 units. These are the first set of codes, no more than one unit per code. Your evaluation codes, assessment codes, a few of the modalities. Here too, there's a couple of the modalities as well, 4 of the modalities as well, and then 4 units. These are going to be your therapeutic procedures, generally capped at 4 units. Again, these are with Medicare. These are just guidelines. Well, other than the evaluations, these are more guidelines. Medicare doesn't hard cap, but when they are, if you do get audited by Medicare, these are the guidelines they use. So be aware of them. And there's just, these are some visit guidelines here. Generally speaking, Medicare only expects between 12 to 18 visits. A lot of therapists go a lot longer than that, but this is kind of where Medicare sees a episode of care between 12 to 18 visits. Documentation can support, of course, support going on beyond that. And again, Medicare does not hard cap the number of visits you can do. Well, other payers do now, but you can, these again, just guidelines. Modalities, usually going to be fewer, usually 1 or 2, or can be done within 3 to 8 visits, things like that. All right, I'm gonna move forward into modifiers. So generally speaking, modifiers and therapy services are pretty straightforward. GP, GO, GN, these are your, you're going to have to use these pretty much for every payer. Some payers are more lenient when it comes to not including these on the claims. Medicare requires it, and a lot of other payers do. It's just a good habit to include these on every claim you have. Just the KX modifier briefly. So now it's going to be 2,410 for PT and SLP combined, 2,330 for OT alone. And remember that one of the important things to remember with the KX modifier, it's not the therapy you have provided for the patient. It's the amount of therapy the patient has used altogether over that year. And of course, it only applies to Medicare Part B. So if the patient's in Advantage or doesn't have Medicare, then it doesn't really matter. But Part B, the KX modifier matters. And so if you may want to ask, especially if you're treating patient later in the year, ask the patient if they've had previous therapy. And then you can also, when you are checking with the MAC, this information is going to be on there as well. And if you're over these amounts, you're going to have to use that KX modifier. If not, you don't have to use that, but if you don't, and they are over, you'll have an automatic denial. So you don't want to lose out because you did not append that modifier. So double check at each visit, especially when you're later in the year when it comes to with a Medicare Part B patient. So just what I just said, when expenses incurred for the beneficiary's outpatient therapy services for the year have exceeded one or both the KX modifier thresholds, the providers use the KX modifier in claims for all subsequent claims for that patient. And this is just your test. It's the amount over this is medically necessary. And if you don't use it and they are over the amount, you'll have an automatic denial. Targeted review. So it's 3,000 for PT, 3,000 and LSLP combined, 3,000 for OT alone. So I say the KX modifier threshold is a yellow flag. Targeted review of 3,000 is a red flag, especially if you have done all the therapy for that patient, that whole 3,000. But it is, again, it's all the patient's therapy, not just the one you have. But it can be a red flag, especially if you've done it all, especially if it's an entire episode of care, you're going to be a red flag for Medicare. And these are some of the reasons Medicare cites for targeting people over that amount. The therapy provider has a high claims denial percentage for therapy services or is less compliant with Medicare requirements in the past. The therapy provider has a pattern of billing for therapy services that is aberrant compared to peers or otherwise questionable billing practices for such services, such as billing medically unlikely units of services a day. So this goes back to those medically unlikely edits. If you've hit those a number of times, you're going to be more likely reviewed. Therapy providers newly enrolled in Medicare, and services are furnished to treat targeted types of medical conditions, so medical conditions that generally have higher episodes of care or higher number of visits, higher number of units than other ones. And then if you're part of a group that has any of those above factors. CQ, CO modifiers, so these are pretty much, they've been doing these for a number of years now. So you're probably pretty used to using these when the assistant has done claims. It does result in that 15% payment reduction. And then now, what you really want to look out for is just, keep an eye on your payers to see if they now require these. A number of the big payers do. And, every year more and more payers are required to use them. So that's really what you should be mostly, looking at is who is now requiring it. When the modifiers are required. So when the assistant furnishes all minutes of service independent of the respective therapist, and when they finish a portion of the services that exceed 10% of the total minutes for that unit, or if it's an untimed one, it's all of it, or it's all or nothing. Excuse me, sorry. When the modifiers are not required, when the therapist, of course, provides all the services, or when the therapist is providing services alongside the assistant, you don't have to use the modifier. It's only when the assistant is doing the services alone. So these modifiers are when you use a ABN. They're not actually required. When it comes to an ABN, only the ABN is required to be signed and dated. This is not going to be, I'm not going to talk much more about the ABN, but I do want to highlight that these are, if you do come across these in the guidance, I just want to explain why they can be used, but probably I'd say most providers out there do not use these correctly. So if you're not using them, you don't need to panic. You just want to make sure you're following the rules of the ABN. But GA, it's waiver of liability statement issued. So report when you issue a mandatory ABN for a service as required and it is on file. You do not need to submit a copy of the ABN, but you must have it available on request. GX, this is when you have a voluntary ABN for a service Medicare never covers, but is statutorily excluded or is not a Medicare benefit. You may use that and you may use it in combination with GY. GY is item or service is statutorily excluded, does not meet the definition of any Medicare benefit. So report Medicare statutorily excludes the item, and you use that with an ABN. And GZ, so this item or service expected to be not denied as not reasonable and necessary, and report when you expect Medicare to deny a payment or service due to lack of medical necessity and when no ABN was issued. If you use these modifiers, though, just a heads up, it will result in an automatic denial. So if you are not sure if Medicare is going to pay, so for example, you're providing a service where you're unsure if it's medically necessary. Most people don't do this, though. You're not sure if Medicare is going to cover it or not, maybe because you're just doing too many services. You may be providing kind of something that's on the border of general exercise and therapy, and you do an ABN and you also submit a claim, and you use modifier, it will be automatically denied. Just saying. And this again, I just put these again, the NCCI modifiers, but I think, adequately just covered those before. So just now into the private payer. So I just highlighted a few of the key kind of billing issues with each one. United Healthcare, CAQ, CO codes are required. United Healthcare does have a multiple procedure payment reduction. You do need to use the GNGO, 4 units max per day. Per discipline. If you have other disciplines treating the patient, you can do more. They do use the total time rule. They say it is following the Medicare guidelines and the 8-minute rule. And now you do have to do prior authorization for Medicare Advantage plans. Prior authorization updates, therapists must continue to submit prior authorization requests for the entire plan of care, including the full duration and number of visits requested. New authorization requests on or after January 13th, so this is already a little dated. Up to the first 6 visits, a member's initial plan of care will be covered without conducting a clinical review when 6 visits take place within 8 weeks of the first date of service. And only care plans requesting more than 6 visits or care plans exceeding 8 weeks will be assessed for medical necessity. The initial evaluation does not require prior authorization. And then services not requiring clinical review, like I just said, up to 6 visits or within 8 weeks. Member is new, a new condition for that evaluation, or has a gap in care of 90 days or more. Cigna, max 4 units per visit a day, and they use the AMA rule. And sometimes, and I've noticed this, and other therapists have noted this as well, is they can switch it up on you. Some days these payers, especially if they've not specified what rule they use, and most payers do not specify, the default is the AMA, they'll come back and review claims and claim that they use the other one, or they'll say, okay, you use AMA, but we actually follow the Medicare rule, or they'll do it vice versa. If they do that, appeal that and make them show where they stated exactly which rule they use. They will generally back down because, like I said before, they rarely say which rule they use. So by default, it's the AMA rule, but unless they say otherwise, you're going to make them show you where in their guidelines, the reimbursement policies or coverage policies, where they specified which unit counting they've done. Humana, you're going to use the CO-CQ modifiers for both Medicare Advantage and commercial plans. Rehabilitative PT and OT in excess of 60 minutes per day is generally not going to be covered, and they use the AMA rule. Aetna, so they have usually going to have a 60-day limit. You may need prior authorization after that 60 days. 4 units max, requires CO-CQ, and they do use a 15-minute payment differential, as do any other payers that require CO-CQ. Oscar Health, they have an MPPR, multiple payment reduction, that works the same way as Medicare, the same way as United Healthcare, require the GNGPGO, and then capped at 60 minutes, and they use the AMA rule. Anthem, they use the GP, they require the modifiers. They don't require CO-CQ yet, but that could change. And this is actually, I just put this in there to show that this is how they described how they use the total time rule rather than the AMA rule. So Anthem is total time. They just describe it kind of goofy in the rule rather than just coming out and say we follow the Medicare guidelines. All right. I do have good news. This kind of just came out yesterday. There are talks between HHS and private insurers to reduce prior authorizations to make the process easier, to streamline it. A couple years ago, the Biden administration issued a huge rule on prior authorization that wouldn't go into effect until 2026 and 2027. That would have greatly reduced the amount. What the Trump administration is doing is they're pursuing a voluntary agreement between HHS and the private insurers to reduce this, rather than putting that rule into effect. Then they said that if private insurers don't go along with this, they may issue a rule that's going to look like though they won't say it, but they'll look like the Biden rule, which will require simplifying the process and making it more standardized and reducing it altogether. And that's probably going to be, really help out therapists, therapy practices that now have to use all these different prior authorization. That's one area will probably be reduced, because prior authorization really does not save any money when it comes to therapy, and it doesn't really save money in general when it comes to therapy. So, that's something to look out for. Is hopefully you'll see, probably won't go into effect until 2026 anyways, but you'll probably see, by then you'll see reductions in the prior authorization requirements. So that is at least good news. All right, so I want to thank everyone for joining me today, and I want to really, please visit the website at therapycomply.com to see kind of everything I have to offer. I really do, a lot more comprehensive services than just CE. I did not do approval for CE for this one, though there are states that I have automatic approval for, so you can send me an email to see which ones that way. The webinar was recorded, and I will, it takes about 20 minutes to process, and after that's processed, I will send out the recording, the link to the recording to everyone, and this will be available indefinitely. You'll be able to always go back and access that link to watch and listen. But anyways, I want to thank everyone for joining me today. If you have any questions about the material in general, please feel free to email me questions throughout the week. I'll be happy to answer those questions for you. And members, remember, you can always ask me any billing or compliance question about any state or federal law at any time. Thank you, and have a wonderful rest of your day.